Good morning. I think we are live. Let's see. I don't see myself. There we go. Hello. Welcome. Welcome to my Ask Me Anything live stream. Got to check my camera there. Okay. So happy to have you guys here. And I'm going to be taking questions live. This is the first time I've done it this way. I went live. I did some live streams back around 2020 during the pandemic, and I took questions ahead of time. So this is the first time I don't know what the questions are going to be. I am prioritizing super chats first, and then in order asked since this live stream has started. And just one caveat to the questions. They don't have to necessarily be about I was going to say a psychiatric issue. They still need to be within the psychiatric realm if it's going to be that kind of question. But other questions like, where do I practice and things like that, you're fine to ask those kind of questions too. And then the other thing is to just be careful. The more succinct the question, the better and the easier for me to answer. My assistant will be posting the questions. So where I'm going with this is it'll be harder to answer a question if it's so long, it needs to be in like 3 different chats or 3 different comments in order to get the whole question. So just be mindful of that. All right. Got to get used to talking to a camera and knowing that you're there, but yet I can't hear you. So used to Zooms. All right, let's go. Let's start with the first question. All right. Hi, Kyle. Kyle says, hi, Dr. Marks. My question is about memory regression therapy. Many in the New Age refer to doing shadow work. Should this therapy be attempted without a therapist? Wow. Okay. So let me say this. Another, I guess, caveat here or qualifier here is that I don't know everything. And so I'm actually not familiar with, can you post that question again or pop it up again? Memory regression therapy. I will say in my mental wellness community, I just did a workshop on different psychotherapies, and I was keeping that brief. And there were still I still think I had a list of probably about 20 different therapies. There are probably over 100 therapies out there that people have constructed and designed that do different things and focus on different things. So even though I'm not familiar with that specific kind of therapy, I will say I haven't been a big proponent or fan of recovering memories and using that as a part of a therapeutic process. And primarily because I think that there's so much that goes on with the formation of memories, and you can dig up things, and your recall can be skewed by your current experience, your current thoughts and feelings about what happened. So if you have a memory that you repressed because, let's say, it's a trauma, so it was a traumatic event, that's usually how that ends up happening with repressed memories. It takes a lot of careful work to make sure that the memory that that's being recovered is accurate and not your kind of skewed version of it now in real time today, thinking back to the past. So my own opinion would be that it would be best done, that kind of work, with someone who is skilled as a therapist to help identify negative assumptions you might be making, or mixing up experiences, things like that. So that's my thought about any kind of work regarding memory work. All right, Jess says, thank you for all your work and efforts to teach us how to take better care of our whole self. Absolutely. I have been I have been missing our standing weekly appointments, but I'm back and excited about another live. Okay, are you talking to I assume you're talking about your weekly, coming in for my weekly videos. It's and I'm not sure if that's what you meant, but I will say that I did have somebody say to me, "Are you still posting on YouTube? Because I haven't seen your stuff in a while." And I'm like, "I've been going weekly with the exception of just a couple of weeks for ever since 2018. But if you start watching something else, you get interested in something, um, the algorithm is gonna show you those videos, and you may not even see mine, but they've been there. So welcome back, Angel. Happy to have you. All right. This is from F. Dear Dr. Tracy, have a sweet and wonderful year 2024. Thank you for your work. Belgian chocolate cheers from Brussels, Europe. Thank you. My late mother-in-law is from or was from Belgium, so we are very Belgium oriented in this house. So thank you for that. All right, handsome Samson. I hope you are handsome. Well, I'm sure you are if you call yourself that. All right. Thank you so much for the super chat, $10 super chat. I've got a question about yourself. You have an excellent speaking style. Thank you. Have you ever considered teaching? And what got you into medicine? And why did you get interested in it, in psychiatric medicine? Thanks for those questions. So, have I ever considered teaching? Uh, so, for what I do as an MD, teaching would be academic medicine, teaching in a medical school. That has not been something I've wanted to do. There's lots of it's not an environment that I would want to be in, lots of requirements, lots of needing to either do a certain amount of research if you're because you're it's about money. Your salary comes either from research and grants or it comes from clinical work. I mean, it's just not for me. I just didn't want to have all of those rules and things that I have to do that get away from actually what you want to do. And that probably isn't a lot different from some teachers' experience with teaching and then having to do all these other things that can get burden them. So teaching in air quotes is my it getting to that point is really kind of why I do what I do on YouTube. I love helping people understand themselves, helping and providing, filling in the gap for what I believe is between actual practice or getting medical care and just knowledge. There's a big knowledge gap. And the way medicine is set up, we just don't have time in a 15-minute appointment, 10-minute appointment to get everything in. So anyway, so this is my substitute for being hired as in a teaching position. And I love it. And I feel like this is legitimate teaching that way. Then as far as getting into medicine, I actually was interested in internal medicine. And if for those who know about the match program, I matched in internal medicine in an internal medicine program in New York City and changed my mind after I did my psychiatric rotation as a medical student because I enjoyed or I got more satisfaction out of helping people with their mental and emotional pain than tweaking blood pressure medications and addressing physical issues. Not that those things aren't important, and they are, but I just found more satisfaction in helping people with the mental part. So that's how I went from regular internal medicine bound to psychiatry. All right, I hope that answers your question. Hi, Luther. Thanks so much for the $20 super chat. I appreciate it. Luther says, I struggle with PTSD and bipolar 2 due to years in the Army and as a police officer. Any job advice for a person like me who struggles to be around people with my condition? Wow. Okay. So, it's hard to overcome the effects of of like first responder PTSD or PTSD that results from being a first responder without professional help. There's, I mean, I hate to say, that you can't help yourself unless you pay for help, but the trauma treatments, finding a therapist who does trauma treatment, is really the best way to mitigate or improve or even resolve your PTSD experiences. So, what I mean by that, or the caveat here, is that so let's say the outcome, the final outcome, won't be that you won't remember these things, or they won't be painful memories for you, or shocking memories, or difficult. What the goal of the trauma treatment is that when you think about these things, you don't have the dramatic effects of it, like shock, um, you know, feeling traumatized. Like, you're able to process it better as a bad memory, but a bad memory that doesn't necessarily keep you from sleeping and give you fear and dread. Or some people, because of traumatic experiences, sorry, my printer's going, um, can start avoiding. So avoidance is a very common coping mechanism that people develop after they've experienced a trauma, to not have to deal with the negative feelings of recalling the experience. Um, so trauma treatments, and there's different kinds, kind of help you reprocess these experiences so that they become memories that are not so painful, and that you're not avoiding, and that you're able to deal with and still feel whole. In the absence of seeing a trauma therapist, um, I would say, the advice or the help of what you could do on your own depends on what you're doing. So if you're avoiding things like not going here or not going there, you don't want to be around people, that's kind of the worst thing you can do, because in the short term, it helps you feel better immediately, but then it just reinforces the avoidance and the bigger and the fear of being exposed to that situation that reminds you of the trauma. So exposing yourself to things that remind you of the trauma is kind of what you need to do to desensitize yourself to the memory of these things. So, if you're having trouble, as just an example, and then I'll wrap this question up, of, say, not wanting to be, I think you said something about not wanting to be around people, or having difficulty being around people, as uncomfortable as that is, you still need to do it in little bite-sized pieces to get to where you are more comfortable being around people, because the more you avoid, the harder it will be to 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 eventually get back to where you were. And then it just, you can just get to where you're not doing anything. The bipolar disorder, unfortunately, can make it even harder to cope. So I guess the bottom line advice would be to really work with a therapist, actually. But there may be some self-help books that you could purchase on coping skills for PTSD, and you would focus on, are you avoiding things and trying to re-expose yourself, or are you having horrible emotional experiences because you're being reminded of these traumatic experiences? And how can you um, get to where you can think about them, where those thoughts are not as intrusive in your everyday life, and when you do think about them, you have less distress. Like, that's the goal. All righty, Veronica Perez, thank you for your super chat. What's the best type of therapy for ADHD and anxiety? I've heard ACT, which is, okay, I'll just read the question. I heard ACT is really helpful in ADHD therapist. Other talk therapy, I can't read. Other talk therapy I've tried are just like venting to friends, but without tools to fix or work through it. Okay, leave that question up for a minute. So ACT is acceptance and commitment therapy. And let's see. And then you mentioned therapy, ADHD and anxiety. Okay, so now you can take that away. So as far as the approach to ADHD, so acceptance and commitment therapy could help you depending on what it is, how the ADHD is impacting you. So if it is affecting your self-esteem, um, acceptance and commitment therapy can help you have more self-compassion. So being easier on yourself and not so self-critical. And it can also help you with um, dealing with the distress of, say, uncomfortable situations. So here's just a random example. I don't know if this applies to you per se, but let's say you have trouble not only paying attention to what people are saying, but interrupting people. And people around you get irritated with you when you interrupt them, or they get to where they just don't want to include you in a conversation, or you're talking and you're like, what'd you say? And they just ignore you because you're always like zoning out and they're tired of that. Like that would be an example of something that could happen as a result of your ADHD that could cause you distress because it's hurtful for your friends to leave you out or people to not include you. So something like ACT could help you kind of it wouldn't help you with the behavior of interrupting and things, but it could help you with processing how you see yourself and maybe even the anxiety that results from those negative experiences. ADHD itself, or the symptoms that can come with that, like the problems with working memory, like executive function problems, the time management, poor organization. I think ADHD coaches are kind of the best solution for that. Is they can help you figure out what are your weak spots, because people with ADHD aren't just globally deficient or don't have problems in just every aspect of their life. There's certain things that you can have superpowers with, and then there's things that you just can't do. And so rather than having more of a focused approach of looking at what are the things that you struggle the most with, and how can we come up with some coping mechanisms and things to do to help you better perform in these areas. So, a very basic, simple thing is having trouble, let's say with time management. Often, people with ADHD who do struggle with time management have we call time blindness, where you have a misperception of how long things should really take. And you may even know that about yourself, but still repeatedly just misjudge how long things should take. And then you may be always late, always scrambling to finish stuff and things like that. So a coach could help you recognize, okay, this is a really difficult area of your life. Let's let's do some exercises where we come up with activities that where you time how long it takes, and that's just a quick example. But I think helping the ADHD coach could help with these skills. When it comes to anxiety, ACT could help with anxiety as well. And then there's also, I think DBT, dialectical behavior therapy, it was originally designed, it's a type of cognitive behavior therapy. It was originally designed for borderline personality disorder. However, I think it can be applicable in a lot of scenarios or situations. It's basically 4 modules: um, mindfulness, uh, interpersonal effectiveness, distress tolerance, and emotion regulation. Well, you may not, with anxiety, let's just say, you may not have wait, let me say this. It is modular, so you can do a couple of modules and not one that's not that applicable for you. So for anxiety, say, distress tolerance is about being able to sit with, and ACT kind of has this framework too of sit with and manage the anxiety as it passes rather than try and avoid it. So you're not trying to run from anxiety, you're trying to not have it run you and be able to manage it and process it. So that's another option for a module of a module of DBT could also be a good intervention or therapy, in my opinion, for anxiety. And one more thing, sorry, it's hard to like for me to not run off, but if you have panic with anxiety, because anxiety has different kind of symptoms. Okay, so if you have a lot of panic and things, exposure therapy could be good for that, and mindfulness as well. Okay, next question. All right, living a dream. Living a dream. Thank you for sharing your knowledge to help people. Oh, you're welcome. I love this. This is much love for all your work. Beautiful. Thank you so much, Salamata Thor. I appreciate it. Pennyworth says, you helped me a lot during my psychiatry rotation. Oh, wow. I really appreciate it. Okay. I helped a colleague. That's wonderful. Okay. Joey says, my 17-year-old daughter has insomnia, depression with passive SI, suicidal ideation, and anxiety. Okay. She's got a lot going on. She's been on Prozac, Paxil, and Zoloft, to name a few. She has initial hypomanic symptoms, then rebound depression. Thoughts? Okay, leave this up for a minute. So she's 17, and it sounds like, Joey, you're saying that I'm not sure if you're saying she's been diagnosed with depression and not bipolar disorder, or maybe she doesn't have a diagnosis yet. So how about this? I mean, given the fact that someone has only treated her with antidepressants, sounds like that's what they believe her diagnosis is, unipolar depression. But if she has initial hypomanic symptoms, I'm assuming you mean initially when she takes the antidepressants. Okay, let me answer the question this way. So, the difference between bipolar disorder, or distinguishing between bipolar disorder and unipolar depression, is not that easy initially. So people can present with first episodes of depression multiple times, and kind of the peak time of it appearing more clear that it's bipolar disorder, maybe sometime in like the early 20s for males and mid to late 20s for females. And then there's some other times in life too where it could rear itself. So that said, you could have a prodrome period. Let's say if your diagnosis is really bipolar disorder, you could have a prodrome period where that starts like looking like anxiety in the teen years with some mixed in depression, and a clue that what we're seeing today, which is an anxiously depressed person, a clue that that's really bipolar disorder, is things like not responding very well to antidepressants. So you take the antidepressant and the person gets worse, they become agitated or hypomanic, like you were saying. So taking antidepressants and having hypomanic symptoms emerge is one of the clues that perhaps that depression is a bipolar depression and not a unipolar depression. Now, sometimes it's not always easy to tell the difference between hypomanic symptoms and anxiety or agitation. So all that to say, the doctor may not get it right at first, as far as, it's a little bit of an iterative process to see what these prodrome symptoms that we're seeing right now that we're going to call anxiety and depression, what it's actually going to mature to be in a few years, or maybe even a year or two. So another clue that maybe it's not unipolar depression and bipolar depression is repeatedly not doing well on multiple antidepressants. So either the emergence of hypomanic symptoms if you take an antidepressant, or just the continual decline and when taking antidepressants and failure to respond, and some of the non-responsiveness is not just that your depression's still there, but it's more of an agitated depression now. So can you put that question up again? I want to look at the last part of it. She's been on Paxil, Prozac, and Zoloft. So yeah, my thought about this idea that she has initial hypomanic symptoms and rebound depression, yes, that's sounding very much like a bipolar. We used to call it bipolar diathesis, but but a bipolar pathway that she might be headed in. And let's just say if I were treating her, no, if I were the parent and taking her to the doctor, now I'm a psychiatrist, but still I'd be like, can we try a mood stabilizer here? But from your perspective as the parent talking to the doctor, the next doctor or the current doctor, I think we doctors should be able to handle patients asking educated questions. And an educated question is, she still is not getting much better despite being on several antidepressants. What do you think about her trying a mood stabilizer? We're in the age now of lots of digital or information online. We all, as doctors, know that. So it shouldn't be a surprise, or it shouldn't be shocking for you to say, I read this or I heard this. What do you think? I'm all for and trying to help move things along in the area of doctors being open to patients asking these kind of educated questions. Now, I've had some people say to me, well, how do I say this to my doctor without insulting them? And that's the point I'm making here, is that, if your doctor isn't, part of it is tone. If you come across with, you haven't mentioned this yet, doc, why not? Because I read this online. I mean, if you come across with an accusatory tone, then yeah, they're going to be defensive. But simply asking, what do you think about this medication? Because I read that this and that gives you the opportunity, or the doctor the opportunity, to educate you on why what you read is incorrect or correct. Like, why hasn't the doctor hasn't started yet or thought or considered a mood stabilizer for your daughter? You don't have to ask that in an accusatory tone, but this is a good opportunity to be educated on why they don't think your daughter needs that. They may tell you, because what I see her having is more of her anxiety taking hold, and what you're thinking is hypomania is more of agitated depression, in which case we think that maybe we should address that with this additional medication. The augmenting, and this will be my last point about this question, so that I don't go on for half an hour about the same question. When someone does not respond to, hold on, my camera, I don't want my camera to turn off. Okay. When someone does not respond adequately to multiple antidepressants, we would consider them treatment resistant. Now, that treatment resistant may be because we got the wrong diagnosis and they really have bipolar disorder, in which case the whole treatment trajectory needs to change. If they're treatment resistant because they have unipolar depression with anxiety, and that just makes it more difficult to treat, then the next step would be to add additional agents, and some of the augmenting agents is what they're called when you add on to your antidepressant would be things like the antipsychotics, like Rexulti, Abilify, adding those to the antidepressant, or also some of the mood stabilizers like Lamictal or lamotrigine could be added to an antidepressant. And one more thing about depression with suicidality that's not responding adequately to an antidepressant, I think you should consider ketamine. Ketamine is probably, yeah, I still think it is number one in treating one of the best agents we have with immediately treating suicidality. ECT is another. So electroconvulsive therapy, that's what ECT stands for. So I know that, I mean, ketamine, that's not an easy answer because if you get the IV, it's expensive. If you go with intranasal ketamine, which is Spravato, if your insurance carries it, it covers it, then you've got a good option there. If your insurance doesn't cover it, then there's an expense that could be the barrier to that treatment. Okay, thanks for that question. Richard Samidra, love your content, Dr. Marks. Thank you so much. All right, James says, thank you, Dr. Tracy, for your incredible knowledge and wisdom. You are truly a blessing. Thank you, James. Appreciate that. All right, let me take a sip of my coffee. Nivea says, Doc, I'm Nivea from Brazil. Hi from Brazil. My daughter is 10 and has ADHD, dyslexia, dyscalculia, and APD. She does speech therapy and psychotherapy. When will I know if it's time to start medication? Okay. So I will say I'm not sure what APD is. I mean, I think antisocial personality disorder. I hope that's not it. Oh, no, or avoidant personality disorder. Usually the PDs is personality disorder, but let's just take that part off. So as far as the medication, I'm going to assume you're talking about for the ADHD. So, and she's in speech therapy and psychotherapy. So medication for ADHD is tricky because for some people, it can be life-changing for them as far as like taking all the kind of loose parts that are just kind of floating around and then just kind of clink and they just come together in order to think and process. However, not all people have as dramatic of a response, and they can come with lots of side effects like change in your mood or change in your appetite. You can get and the change in the mood can be either from the withdrawal or the come down effect of it. So like taking a stimulant, you feel it work and then you stop taking it, or it wears off, and then you feel this like drop in your mood and how you feel, almost like an emotional crash. And then some people, they may not feel like emotionally down, but they can feel stilted, like their personality changes. I've had some people say they feel like they can't speak, like their mouth won't work. So if they took Adderall or they took any stimulant, I shouldn't just say Adderall, but took a stimulant and have some like work thing to go to, they can't go because they know that they're not going to be able to talk. So back to your question of how do you know when to start medicine? It's really a very personal decision because it's a threshold issue. It really matters based on how bad is the impairment. So, is your child, for example, if your child is failing class, well, she's 10, but if your child in school is not performing at all, thank you for putting the question back up. Yeah, if she's, like, not performing at all, the teachers are saying she's just not even grasping the information because she can't seem to pay attention long enough and things like that, then you may want to, consider trying medication with her to see the difference it makes. So really it's about how much of a problem does it present? If the problem is more hyperactivity and the child is, going to the principal's office every day and getting into lots of trouble, you may want to consider putting her on medication versus behavioral issues because of the hyperactivity, but some redirecting helps her, putting her in the front of the class or even having, you're in Brazil, here in the United States, they'll have individualized education plans are called. Maybe you have something similar that for people who have a medical issue that it affects their learning and their school performance. So in this scenario, a potential intervention that she could get with an individualized plan if she were having like hyperactivity that was getting in the way of her school performance would be to have like an extra aide in the room who helps redirect her and things like that. So the final answer is the decision about starting medication depends on how badly the symptoms are affecting her school performance and maybe even at home behavior. Oftentimes, it's not that uncommon for the at home behavior to be okay, but it's the school performance that is the problem, or vice versa, that they're doing okay at school, but at home, it's just a mess every time they come home. As far as meltdowns and behavior problems, not listening and all of that. And if you can find other ways to get a handle on that behavior, then you could get by without medication because she's still like doing all right in school kind of thing. So it really just depends on how bad is it and whether or not then you want to introduce medication to improve it. And that's for the person who's hesitant. Some people aren't hesitant at all, and they're like, my child is having some issues. It's not severe, but it's still impactful. So let's try medication. All right. Thank you for the super chat. Just saying. ADH sleep issues for teenage son. What do you suggest? Is resistant to old school methods. He's being affected mentally, bad mood. Okay, I'm laughing because I live this issue. My teenage son has serious sleeping issues, and so how do I answer this? I don't know what your old school methods are. When I think of old school methods, I think of like, well, from where I'm from in the South, it'd be punishment. And if you don't do this, you don't get this, and et cetera, et cetera. But that doesn't work. All that does is just reinforce that they're flawed and you're punishing. I'm not saying you're doing this, but in the scenario of like punishing someone for still being asleep and oversleeping their alarm clock, you're punishing them for something they can't help or control that well. Now you might say, well, they can control it, just get up. But you can have, someone who's got so with ADHD and sleep issues, I have a video talking about this with the body clock. Part of the problem is the body clock is off. It's not just, oh, they stayed up too late and therefore they're sleepy in the morning. It's a body clock issue being shifted so where they can't, no matter their best efforts, like feel sleepy and just go to bed at say 11 o'clock. Like they still have the energy and that energy doesn't wind down until sometime after midnight, usually. So then they're forced to get up in the morning and they're still in a kind of a deep sleep phase when the alarm goes off and they can't just push through. And it's just a continuous cycle. So what do I suggest? So, I think that, if your child is seeing a doctor or seeing a doctor, because like pediatrician or psychiatrist doesn't necessarily have to be a psychiatrist. Here in the US, some pediatricians will also treat ADHD. Getting a sleep aid, if you're open to that. Sometimes that's just the only way your child is going to be able to go to sleep before their body is ready for them to go to sleep. And it is a cycle that just kind of restarts each day. So it's not like, okay, let's take something for sleep, and if he or she sleeps for a couple of days and gets some good sleep for a week, okay, now let's see if they can sleep on their own. The body clock, if it's shifted, is just going to do what it normally does again. So some children will grow out of this, or it will improve. They may not grow out of it to the degree that, okay, now they're falling asleep at 9 o'clock, but they still may be shifted a little bit to the later evenings, but not as bad as during these teenage years. Non-prescription medication would be, prescription medications that but anyway, your child's doctor could consider would be things like trazodone, or you're in a different country, but clonidine is another one that I think some pediatricians will use for children for its sedating effects. Non-prescription would be something like melatonin. And I do have a video on my channel talking in more detail about carefully timing melatonin to take about 4 hours before you want to go to sleep to shift your body clock. That's the purpose of that. That would be something that I would suggest as well. Also, or that could be helpful, wearing, so my son, for example, I know he doesn't mind me talking about this because I've talked about him before, will we do the blue light blocking glasses 2 hours before bed, and I'm having to remind him, put your glasses on. So he and I both are wearing glasses at night to block the effect of the blue light, because if they're on their phone or even watching television in their room or something, that can prevent their natural release of melatonin, which then can help fall asleep, etc. So they can get in bed and still be activated. But yeah, those behavioral interventions like blue light blocking glasses, and eye covers at night, if the room isn't that dark, can only go so far. It may still really involve the need for something like melatonin or a sleep aid just to help them get through these years of having trouble falling asleep at a reasonable time. Okay, thanks for that question. Being better. Hi, Dr. Tracy. I'm listening in this morning while getting breakfast ready. Your subjects are so interesting. Thank you. Thanks for popping in. Being better has been around for a long time. Missy Roselle. Hi, Doc. I love what you do. Thank you. Thank you. Thanks for being here. And then, I don't want to botch your name, Sorenable. Lots of love. Lots and lots of love from Ireland. Thank you. I guess it's now early afternoon for you in Ireland. Thank you. OCD and anxiety. Great work as always. Thank you. All right. Thanks for the super chat, Ash Eternal. I watched your video and bought 15 milligrams of L-methylfolate with 10 milligrams of Lexapro. Is that dosage too high? Also, what's the downside of L-methylfolate? So thank you for that question. L-methylfolate, the normal dose of L-methylfolate to take as a supplement is 15 milligrams. So that is not too high. I'm not even sure if there is a 30 milligram dosage, but there might be. But anyway, 15 milligrams is the normal. And 10 milligrams of Lexapro, I'm not sure if you're asking if that dose is too high. The normal dose, but I'll go ahead and comment on that. The normal dose of Lexapro for depression is 10 to 20 milligrams. And then for anxiety is 30 to 40 milligrams. That's kind of the typical range that we will use prescribing Lexapro. What's the downside to L-methylfolate? There really isn't much downside except if you are B12 deficient and don't know it, the L-methylfolate could kind of interfere with recognizing that because it could correct some anemia issues. Um, Aside from that, I don't even think that there's a whole lot of side effects to L-methylfolate. Let me pull up my app real quick that I use whenever I am doing medication checks, interactions. Let's see here. Of course, now that I'm doing this live, it's going to be slow. Methyl. Okay, L-methylfolate, which by the way is considered a medical food. Adverse effects. What does it say? Frequency not defined, altered sleep patterns, difficulty concentrating, irritability, overactivity, excitement, confusion, impaired judgment, nausea. I don't have a ton of people on L-methylfolate. Some. I've never had anyone report a side effect from it. Now, some of these things that I just read to you that are probably post-marketing reports of people experiencing this, and then like they still have to just list it that this could happen because it happened to somebody. And a problem with some of these kinds of reported symptoms is you don't always know if it's strictly from that drug or thing you took or because of an interaction with something else. So that's kind of my general thoughts about downsides of L-methylfolate. I think it's very well tolerated without a lot of problems. It's basically a vitamin. Essentially, it's the active form of the vitamin that you're taking. Folic acid being the non-active form. So that's that. All right. Next question. Surrealist Idealist. Thanks for the super chat. Like that name. How concerned are you about COVID and long COVID in 2024, particularly about brain fog, chronic fatigue, and reduced ability to exercise? I think I've probably just tried to be in denial about long COVID. I read about it from time to time. The issue for me is we still don't know a lot about it. We still don't have our brains wrapped around it enough to speak about it in a way that's can predict what are we going to end up with here. I mean, we're still learning. And so I've hesitated on even talking about it because I don't like talking about things and where there's not a good answer or a good intervention, just, kind of raise this situation and get people upset and scared. I'm not even sure of the percentage of people who get long COVID as a result of COVID. Probably the infectious disease experts maybe have a better sense of that. I've had patients who are still having trouble with it. And it's distressing and discouraging because even with them, I'm not sure what to do. I'll say that they need to see a neurologist. I don't know if the neurologists know what to do. So how concerned am I about it? I guess because I don't hear a ton about it and it's something I don't know what we're going to do about. I just kind of block it out and try not to think about it. So I guess it's not top of mind for me, but it is concerning. It's very concerning. And not so much that I don't want to go anywhere and I've stopped wearing masks all the time. I was probably one of those people who was wearing masks a long time after we got the okay to stop wearing them or after the mandates, because I was scared of the long COVID thing. Because I'm like, my job, my work is dependent on my ability to think. And if I can't think, I'm done. So, to that extent, I went a long time being afraid to take my mask off and getting every vaccination and all that because I didn't want to get long COVID. Um, but it's still a little, it's still, I'm not hearing as much about it um, lately. So I don't know what the outlook is for 2024. Fortunately, and this isn't say anything about vaccines versus not, but I will say, I mean, fortunately, since vaccines, people have had lesser um the lesser forms of it. Like they get infected and it's more like a cold than it being devastating and killing all these people like it once did before we had the vaccine. So I'm encouraged, at least in that regard, that people are getting less sick when they do get it, but that still doesn't, I mean, people are still getting long COVID too. So that's that. I don't know. I don't have an answer. I wish we did have answers. All right. Uh Lovey Pink says, very grateful that you exist. Your videos are very helpful. Love from India. Thank you. I'm glad they are helping you and that you're finding them helpful because that's why I'm here. All right. Mike Eggenberger says, can you comment on dialogue therapy? Do you find it helpful? Okay. So this is another therapy that I am not familiar with. I'll just have to admit there's lots of therapies out there. Um, so I am a little familiar with what's called narrative therapy. And if this is anything similar, well, I don't even want to guess. I'm sorry, Mike. I don't know what dialogue therapy is. All right. Beth says, thank you for sharing your time and wisdom with us. I'm 61 and was diagnosed with inattentive ADHD 5 years ago. I supplement my therapy with your videos. Thank you. Blessings from Mississippi. You're welcome, Beth. I'm glad they are a supplement. That's funny, a supplement. That's kind of how I started it out, as a supplement for my patients, because since I was trained as a therapist, or sorry, I was trained to do therapy. I was trained as a psychiatrist, but in my program, it was a heavy emphasis on therapy. Um, I want to spend the hour or half hour talking about their life and not just talking about, okay, what are your side effects and this and that. Not to diminish those things; those are important. But I did want to spend more time talking about other things. So rather than launch into a lecture about you know how to tell the difference between depression and bipolar disorder, whatever the case is, something explaining things, I would make these videos and then say, hey, go check out my video on this. And now let's get back to talking about your relationship. That's kind of how I saw it. So it was a supplement even then. Okay, I'm ready for the question. So Erica, thank you for the super chat. Hi, Dr. Tracy. I'm a med student and got a question for you. Okay. How many antidepressants can we combine combine on the treatment for severe depression? I've seen patients with 3, never seen more than that. Yeah. So the question is, I'll repeat it. How many antidepressants for someone with depression, severe depression, how many antidepressants can they be taking at one time? So this is a little bit of a form issue. Like there's not a rule, okay, that you can't do more than this. I was trained, and even in my own just practice, I don't do more than 2 because I just don't see the benefit of adding more than 2. The more you add, the more side effects you subject someone to, and particularly with regards to developing serotonin syndrome if you add multiple antidepressants. So I don't know that I've ever seen someone with 4. I if I were to see someone in practice, came to me, new patient, and they were already on 3, I'd be looking to get them off that 3rd one, depending on what it was. But, you know, there's only so many categories that we have with the antidepressants. We have the selective serotonin reuptake inhibitors. We have Wellbutrin, which is in its own category, enhancing norepinephrine and dopamine. And then we have the receptor drugs, or at least that's what I call them, the ones that increase serotonin with some reuptake mechanism, but also by enhancing or activating other serotonin receptors. And those drugs would be things like Trintellix and Viibryd. Oh, and then there's the serotonin norepinephrine reuptake inhibitors like Cymbalta and Effexor. So, you know, a typical combo could be Lexapro or a serotonin enhancing agent, and then Wellbutrin adding to that. But there's kind of not a good reason to add 2 serotonin reuptake inhibitors for an additive effect of increased reuptake inhibition. I'm not even sure that there's an additional benefit that way. So sometimes people will say, okay, well, Prozac will prevent reuptake, block reuptake. Then I'm going to add, sorry, this is getting a little bit too much in the weeds, but I still want to address this since you asked the question. And then if we add something like Cymbalta, you've got the norepinephrine enhancement in addition to the serotonin. So you got these 2. Then if we add Trintellix, like I don't even see why. I think that's just too much serotonin activation to have 3 antidepressants, frankly. And again, puts people at risk of serotonin syndrome, which I know is rare, but it might be less rare if, you know, if a lot of people are stacking up the antidepressants like that. That's my opinion on that. So in lieu of adding multiple antidepressants on top of each other, if you're going to add meds, I think it's better to add an augmenting agent, like, you know, the antidepressant plus an antipsychotic, or perhaps 2 antidepressants and an antipsychotic or something. But yeah, my opinion is I don't really even see a good utility for 3 antidepressants. Okay. Thanks for that. All right, Derek, your videos are really helpful to me and my children as we're struggling to access resources to get a diagnosis, potentially ASD, where we live, French colony of Martinique, in the Caribbean. Thank you. Yes, Dark was your name. Can you pop that up again? Okay. So I'm glad my videos are helpful for you that way. Admittedly, I don't have a lot on autism spectrum disorder. And it's I have to admit, it's a little out of my wheelhouse in terms of the reason. So let me put it this way. With autism spectrum disorder, most times the diagnosis comes early on. So certain things would be recognized, you know, as far as how the child reacts to people, maybe very sensitive, have these sensory experiences that send them into meltdown mode, don't want to touch people or be touched, have language delays. Like those are the things that often bring the diagnosis of ASD to the forefront. So because of that, and I don't treat children, that like whole process of getting a diagnosis for autism spectrum is not part of what I do. And I'm just saying this to explain why I don't have a lot of autism spectrum videos on my channel. The adult with autism spectrum may come to see me as an adult psychiatrist for just a general psychiatric issue, because you can still get depressed, you can still have bipolar disorder, you can still have, and ADHD is often comorbid with it, meaning it's very common for the two to come together to have autism spectrum and then also have ADHD. So I'm not involved very much at all, really, in the process of diagnosing people with autism spectrum. So yeah, so that's I'm going off on a tangent. Sorry, but that's why I don't have a lot of like how to or recognizing ASD in children. I don't have a lot of that on my video, but nonetheless, I am glad that what I am talking about, which will still be relevant and as time goes on, is helpful for you to supplement what you're getting. Okay, Shay. Doctor, please make a video about critical thinking or problem solving or intelligence. Critical thinking or problem solving or intelligence. Okay, Shay. I mean, it'd be helpful to know a little bit, like to have an emphasis, because I'm glad you asked the question like this, because I will get comments often about, will you make a video about this? And if you follow my channel, you'll see I do make a number of videos that are based on viewer questions. But I like to have an angle to go on rather than just kind of generally speak, like in this case, about critical thinking or intelligence. Like that could go on for a long time and bore you guys to tears and you not even watch it, because I'm just kind of talking about intelligence versus something more like how is intelligence determined? How does it affect your life? Now you might be saying, yeah, that's what I want you to talk about. But so all I'm saying, I guess, in this comment is I will consider those topics, but I would have to think about how I'd want to angle it to be applicable or have it be useful rather than just talking about critical thinking. Some people are not as good at that as others. And so yeah, thanks for that suggestion. I'll give that some thought. Okay, Mila Cohen. Hi, Dr. Marks, huge fan. Thanks for all your wonderful work. Thanks so much, Mila. All right, I'm sorry to botch your name. Pandaradan. Thank you for the super chat. Hi, Dr. Marks. What could be considered clinical experience for someone looking to become an assistant psychologist? Okay. So qualifier here is I'm not a psychologist. And so I don't know all the rules of licensure, but I'll tell you what I do know. So assistant psychologist. So it sounds like maybe I'm not sure if you're in the United States. Oh, I see was that a pound sign? So what you may call it if you're in the UK is maybe different for what we call it here. But here in the United States, you can get a bachelor's, a master's, PsyD, or PhD, doctorate level in psychology. My understanding is to be a licensed psychologist, you have to get a doctorate level degree in psychology, and then have put in so many clinical hours that's supervised before you can be considered licensed. If you stop at the master's level, then you're not a licensed psychologist, but you could still do some kinds of work. And the entity that hires you would make that determination whether you're qualified or not. So some master's level psychologists may work in schools as a school psychologist. Also, here in the US, a licensed therapist can have a master's in psychology. So licensed therapist, LPC, like licensed professional counselor, or marriage and family, LMFT, licensed family. I can't get, but family therapist. Sorry for messing that up, but I know it's LMFT. Though that is usually a master's level degree in something. It doesn't have to be psychology, but then there's certain requirements of clinical work, so many hours. I don't know the hours, but so many hours that they have to do in a supervised setting to then sit for certain exams and then get licensed. So I'm not familiar with the term assistant psychologist. But here in the US, they'll often say licensed psychologist. Some people, if I get interviewed for like television or something, they'll call me a licensed psychiatrist, and we don't call it licensed. I get a license, but that's not what we call it. Licensed psychiatrist. That's more for licensed psychologists, that distinguishes them from, say, a master's level psychologist or a psychologist who just didn't go through the whole like clinical work and then licensure process. Maybe they're doing research somewhere and don't need that qualification. Okay, thanks for that question. Arafath Nihir. Sorry, messed that up. Arafath, I love your ADHD videos. It's helping me every single day. Nice. Thank you. Thank you. I have a personal soft spot for that diagnosis. So B, do you think antidepressants can mask problems that need to be fixed instead of actually fixing them? Do I think let me read that again. Do you think antidepressants can mask problems that need to be fixed instead of actually fixing them? Very good question. I actually had a conversation just recently with someone about this. So I think I'm thinking of the way to answer this. So I guess the bottom line answer is I don't think antidepressants, the medication, masks the problem. And that's actually a fairly common, I think, misconception that people will have, that I don't want to take medicine that makes me, not that makes me not experience this, or I just need to work through this myself. I don't need medicines to just turn me into a zombie. Well, if it turns you into a zombie, those are side effects. That's not the therapeutic effect of the medication. What the antidepressant is supposed to do is reduce the intensity of your symptoms so that you can get to the point where you can function and that the symptoms are not getting in the way of your daily activities. So, and maybe even take some of them completely away. So, for example, hopelessness. If you just started feeling like, what's the point? Why am I even here? Like, I can't even like get up and out of my bed to go to work or school and da 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 da. The antidepressant should, if it works, help you not feel hopeless. Now, you still might not like your life situation. Like you might not like your job or your school, you hate going to school, but the antidepressant isn't going to make you not hate going to school, but it should, if it's working, make you not have so much dread and feelings of despair, I guess, about going to school. Like so you still have the emotion of, I don't like this thing, but the intensity of it isn't so great that it holds you back from doing something. I guess that's a way to describe that. Another kind of angle of this question or implication of this question is that can the antidepressant fix a problem? And that's where I think having realistic expectations helps. So I had a conversation with someone who was like, I need my antidepressant changed because I'm putting other people before myself too much, and I'm not getting my stuff done. And it's just making me feel bad. So, I'm trying to understand exactly what this person has experienced. Like, why are you not putting yourself first? A depression symptom reason that you might not put yourself first is because you feel like you're not worthy, or you feel hopeless, or you can't get yourself moving in the mornings, or you just don't really want to be around, or you're zoning out. I mean, sometimes you get depressed, people can just be sitting there, not completely unstimulated, doing nothing, and not even realizing that like time is passing and they're just staring into space. Now, that doesn't happen to everyone, but that can happen. Or if that's happening, you're not getting things done. That's not what this person said. That's not those would be kind of depression reasons. You're not putting yourself first. A non-depression reason is you just don't prioritize yourself. Like everybody else's needs comes first. That's a personality issue, or that's a how you see yourself issue. I actually have a video coming up about boundaries and narrative identities. Stay tuned. But the point is, an antidepressant is not going to make you put yourself first or stop deprioritizing your needs if that's your personality to do that. The antidepressant isn't going to change that. So the antidepressant may make you not cry every day and may make you have more energy and increase your appetite and help your sleep and all that. And therefore now you feel more motivated to take care of yourself and do this and that and the other. But that's a different reason why you're now prioritizing yourself, because you have more energy behind it to do it, but you still have to make that decision that that's important to you to do. So that's an example of how the antidepressant doesn't fix like a behavioral problem or a personality style, or, you're not getting along with somebody and you need to work on your relationship with that person. The antidepressant isn't going to fix the relationship unless the reason you are having problems is because you're so depressed, you're irritable, you don't want to do anything, and you're neglecting people, things like that. Those symptoms are getting in the way. All right, hope that answers your question. All right, Victor, Terry. Hi, Dr. Tracy. Your videos are very informative and helpful. You encouraged me to get certified as a mental health youth first elder, as a youth mentor. Wonderful. I'm so glad, Victor. That makes me happy. Very good. Keep up the great work. Christy Eisen. I don't have my glasses on. Hi, Dr. Marks. Your work has helped me so much. I have a hard time with psychotic depression. I am on 2 mood stabilizers and now my TSH is high. Do you think if I get the TSH on level, will it help? Okay, hold that question up a minute. So Christy is saying she has psychotic depression and taking 2 mood stabilizers. And now you have a high TSH. TSH is thyroid stimulating hormone, and it's an indicator of an underactive thyroid. It's kind of this inverse relationship. So a high thyroid stimulating hormone, TSH, means your thyroid is not producing enough thyroid hormone. If your TSH is low, it means you're overproducing thyroid hormone. It's a feedback loop. So with a high TSH level, it means you have an underactive thyroid, kind of like hypothyroidism. And then, do you think if I get the TSH on level, it will help? So yes. I do think if you have what would be considered then hypothyroidism or underactive thyroid, that low thyroid production or underactivity could be affecting your depression or making your depression not respond well enough to medication, because hypothyroidism can look very much like depression. Now, there are other physical symptoms that can go along with it. People can feel have temperature dysregulation, like feel cold and things. You can change the texture of your skin. You can lose your hair or have it thin, not necessarily lose it, like come out in lumps, but like thin. So there's other affect your appetite, gain weight. So So there's other physical symptoms that can go along with hypothyroidism, but the way it affects your brain is it can also worsen depression or cause depression symptoms. And so you could be on the best antidepressant regimen there is, but if you also are hypothyroid at the time, it's going to be hard for you to respond adequately, or for your depression to respond adequately to your depression regimen. So having your thyroid checked and monitored is an important part of your overall, well, your physical treatment too, but your psychiatric treatment as well. So it would be important. So yes, I am hopeful that if you got thyroid supplementation, if that's the treatment that you need, if you got thyroid supplementation and your thyroid was normalized, that should improve your depression. It may not, though, go all the way, especially with the psychotic depression. I don't know that it would reverse psychosis unless, so that may involve like having your other medications tweaked. But yeah, think of the hypothyroidism as like a weight that's holding you down, and you just can't, like an anchor, and you just can't, you got to break loose from that and kind of get that normalized. And one more thing, once you get it normalized, you're going to need to keep up with, and I'm sure whoever prescribes your thyroid medication will have you do regular blood monitoring of it, because things can change. You can have shifts and then kind of notice that, okay, I feel better, but now 6 months later, or a year, you're like, I'm not feeling so good anymore. And then rather than like having your psychiatrist immediately change your antidepressant, you need to check your thyroid to make sure things didn't shift. Okay. Next question. Let me take a sip. Oh, Minister Roxanne Rogiers. Dr. Marks, why do doctors force patients off benzos when those meds help us to function normally? Thank you for this question. Force people off benzos. Okay. So, that's a very loaded question because, I would say if okay, let me answer it this way. So I have patients who have taken benzodiazepines for years, 20 years or more. Okay. I'm not forcing them off the benzos. But what I will do is I will heavily, and I will get people to reduce their benzo dosage if they are continuing, or I will limit how much benzo they can take if they are continuing to increase the dose. So an indication that a doctor may want to either get you off the benzos or limit how much you take or reduce your dose is if you're continuing to need higher and higher doses. So benzodiazepines, they're used to treat anxiety. They're also used for other things too, but psychiatry, you'll use them to treat anxiety. And yes, they're very effective. However, they're habit forming in the sense that you can develop a tolerance to them over time. So you can start out, let's just say, I'll just use Klonopin as an example, clonazepam. You may start out with 0.5 milligrams and you take it once or twice a day as needed for anxiety. And then that as needed becomes pretty much a daily thing. You start taking it every day, and then maybe twice a day. And then next thing, that 0.5 isn't working anymore. You start running out of pills, because then this is how it could look for someone who's escalating the dose. That's what I'm talking about now. So then I'm getting a call that from pharmacy or from you that you need an early refill because that 0.5 isn't working anymore. You had to double up. That's a problem. So when that happens, when I get I'm doubling up, well, we need to have a conversation about that. And I will warn the person, okay, well, you don't want to go down this road. Like if you're having lots of anxiety, this increase is not going to be your last increase. And people will think, well, okay, this is it. If I could just get on, you started me with 0.5, but if I could just do 1 twice a day, I'll be good. I know because I've been doing that, for a little while now, and I know that. Okay. So I'll say, okay, all right, let's try that. And sometimes they can stay there, and then sometimes they can. They'll be like, can we just go a little higher? And so it can be dangerous to go, or it is dangerous to go up too high. You can get to where you max out the medication. You can't take any more safely. And here's what can happen if you, let's say you're taking a pretty hefty dose. What would I consider a hefty dose? The 2 milligram tablets for clonazepam are the highest pill size that they sell. And once somebody is needing a 2 milligram, I'm like, red flag here. We got to do something different if you can't just manage with this too. For somebody to take like one of those 3 times a day, I think that's a pretty large dose. So let's say you are taking 2 milligrams 3 times a day. And your doctor says, I'm not going up higher because it's dangerous for you to take too much. And you say, okay, fine, I'll just deal with this. If the doctor doesn't try and get you to wean down, what could happen is the next tolerance level that you experience it, but your doctor's not going to go up anymore. And now you start having withdrawal symptoms. So now you're taking 6 milligrams of Klonopin a day, and you're having withdrawal. You're waking up in a panic, or you're, sweating, attacks of anxiety during the day because the medicines wore off, all that it becomes an absolute nightmare. And so now, you're in a bad spot, and the doctor is now going to have to do a lot of work to try and wean you down. And by that point, they may say you need to go to a detox and have this done in a supervised setting. A danger of suddenly just stopping benzodiazepines, the worst case scenario is that someone has a seizure. Not everyone does, but it is a possibility, especially when you're on really high doses. And then you stop suddenly because why would you stop suddenly? Because you ran out of pills, because you were taking more and running out of the pills. So that is why that's a scenario. That's a very bad scenario to get to. And that is why doctors may force someone off the benzos, and not force in the sense of, okay, this is your last script. You're on 6. Oh, well, go make it work for yourself. It means like needing to responsibly help you wean down. And if you've been taking them for a long time, that process can take a long time. And usually if I have a patient who's been on a benzo for 10 years, we'll talk about, even if they're not increasing the dose, we'll talk about, how long you want to stay on this, because long-term benzo use does have a negative effect of making you less sharp. And it may not be something that's noticeable to you, like, gosh, I can't even think. I mean, it's not that obvious. It's more like you're just not quite sharp. And then if you were get off, you'd see it's like, whoa, okay, yeah, these thoughts come together faster. This came to me faster, and that. And the older you get, the greater the impact of that dulling. Now, some people are fine with that because you can't see the difference until you get off. You're like, well, I'm still, I'm not fired, so I'm still working, so I'm good with this. But so I kind of went down a rabbit hole a little bit with this, but the kind of top level answer here is that benzodiazepines, while very useful and helpful, you have to be careful taking them long term, and especially if you are developing tolerance to where you're needing to increase the dose. And that needing to increase the dose is usually the red flag that will trigger the reaction from the doctor to either wean you all the way off or do something to help you get on a lower dose. And what could that something be? Address it, if you're taking it for anxiety, addressing your anxiety differently. And I've had some people who were very resistant to wanting to use anything other than the benzo for their anxiety. And I think that's a bad approach, because if that's the only thing that's treating your anxiety, I think you're more likely to end up needing more and more because of the tolerance issue, versus being on, say, an antidepressant, which is the primary treatment for anxiety, and having the benzodiazepine be for breakthrough anxiety. So you get stabilized on the antidepressant, and then let's say there's just a stressful situation going on right now, and your anxiety is temporarily worse or transiently worse. So you take the benzo for that period of time. It could be weeks. You get through that, storm's over, and then you're not using the benzo as much anymore, and you're back to your baseline of taking your antidepressant for anxiety. Like that's the ideal scenario of how the benzo can work for years for somebody in conjunction with something else for anxiety. Another good medication, in my opinion, for anxiety is Lyrica, pregabalin, in lieu of instead of the antidepressant. So, all right. Thank you for that question. Barriets, thanks for your question. Just wanted to say a big thanks. I can't read again. I'm a bad reader. Just want to say a big thanks you for your engagement on YouTube. Thank you. Thank you very much. I appreciate that. Robin Mankiller. Watch it, Robin. Gratitude for you and the universe. Thank you, Robin. Benita, I'm not going to say your last name. I don't want to mess it up. Do you offer support outside of the US? I do not. Thank you for asking that question publicly, because I get quite a few inquiries about, am I taking new patients? So in general, so more specifically for me, I'm not taking new patients. I have been practicing out past my training period for, well, let's see, I finished my general psychiatry training in 2000. So this is my 24th year post-residency. And I thoroughly enjoy teaching on YouTube. As I get older, it's harder to do on a regular basis. It's hard to put a lot of energy into this and a lot of energy into a full-time practice. So I made the decision, I think it was 2021, I think, because I was writing my book then, that I wanted to leave space for me to do some other things other than just have everyday be patients all day long. So I stopped taking new patients. I still have my current patients. So I still have a practice. I still see patients. I just don't see them every day anymore. As far as outside of the US, though, this is I want to answer this generally speaking, irrespective of me not taking new patients. In the US, doctors, people with licenses, whether it be physicians or therapists, states require that you be licensed in the state where the person you're treating lives. So I'm in Georgia. I'm licensed to treat people in Georgia. I'm not licensed to treat someone in Montana. So if I have a patient who then moves to Montana, they've got to find someone who has a Montana license. Even if the treatment is remote, they still have to have a state license in that state. When it comes to out of the country, that is not regulated. So it kind of, I guess, depends on the person's comfort level with treating someone out of the country, because there's not a state license that's saying you're doing wrong by seeing someone. The authority that is handing down the verdict on whether you're doing something wrong is the state where the patient is. So if you're in a country that doesn't care that a Georgia physician is treating you, then that's not an issue. However, I do think it could become not an ideal scenario if for someone who's not stable, but not stable in the sense of perhaps you get to the point where you need hospitalization. Well, I don't know any resources outside the country. Now, granted, still this doesn't apply to me, but I'm just speaking generally. If you were asked this question of anyone here in the US, they may hesitate because or they may it may the answer to whether or not they do it may depend on the nature of your treatment. So if they're doing therapy or coaching, so coaching, one of the ways people will get around the whole licensure issue here in the US is then to say, well, I'm doing coaching with this person. It's not therapy under my medical license or therapist license, it's coaching. But if you have a disorder that may end up in a hospitalization because your symptoms get severe, then that person really isn't going to know what kind of resources to refer you to. So that may make them not feel comfortable treating you outside of the country. But if they're doing therapy and, there's not really a hospitalization potential, or at least, not foreseeable, then they may feel comfortable doing that. But I am not, just because I don't have the time to take on any more people doing one-to-ones. All right, Sir Rob, I think you're doing a magnificent job. You are very knowledgeable. Thank you. Thank you, Sir Rob. I love what I do. I just love what I do. All right, Damo347. Love all your vids. Thank you. Thank you. Luke, thanks for answering the benzo question. Very informative as I am on Klonopin. Yeah, for me, my preferred benzos that I use, I know you didn't ask this question, but I'll just elaborate, are clonazepam because it's long acting, lorazepam, it's a little shorter acting than clonazepam, and then Valium as well, diazepam. I have a tolerance-hate relationship with Xanax alprazolam, and I say tolerance because it's very effective. Now, there are people who will take it and say, oh, it's made me really tired, I can't tolerate it. Okay. But it is a very short-acting benzodiazepine. Short-acting versus long-acting has implications on the withdrawal effect after the medication wears off. So shorter acting medications have more of a sharper edge to their drop off, which could then leave you feeling more anxious or having a rebound anxiety effect when it wears off. And that tends to be more pronounced when you take the medication more regularly. So Xanax has a greater potential, because of its short-acting nature, to pull people into a dependence more. I've seen people where, Xanax, you can take it up to 4 times a day because of the short-acting nature of it. And if they do get to where they're taking it 4 times a day, they're like looking at their watch of, okay, I got 30 more minutes before I can take my next pill. Like, it can be like that. Again, that doesn't happen to everyone. There are people who take Xanax daily and never have a problem because they don't develop a tolerance. And they don't have a withdrawal. They don't have a rebound effect when the medicine wears off. And if that's you, then, good for you. And I'm glad it's not presenting a problem for you. But because of its short-acting nature, it has a greater potential to cause those kinds of problems of rebound anxiety when it wears off, and develop a more tolerance to it, to where you need higher doses and all of that. Okay, the skinny on the benzos. All right, I do not want to botch your name with these accent marks. Mathematicar. I botched it anyway. Thank you for the super chat. Hi from Croatia. Thank you. What's your opinion on treating schizoid personality disorder medically? I'm on Wellbutrin, still have motivation issues. I also have avoidant traits. That's a great question. Schizoid personality is one of the personality disorders that kind of the predominant the predominant presentation of it is one of a detachment from others, um, uh, maybe even, people can be, you might think of this person as a loner. Um, at least that's what we would say here in the US. And I don't mean that negatively necessarily. Or they can also, a good part is you could feel like you don't really need people and you're fine with that kind of thing versus someone not having people and being lonely. Um, and there is a little bit, well, so anyway, I was going to say there's a little bit of connection with uh schizoid and schizophrenia, just a hair. It's more the schizotypal personality that has more the connection to schizophrenia. All right, long story though. I don't have a high opinion on using medications to treat personality issues because that's not what the medicines are for. The medicines are for treating symptoms that could bleed into how you express your personality, but it's not really going to change your core personality. Um, so for example, here's the way, a more indirect way you could be treating something that's personality based, but it's still not treating the personality. So let's say with your schizoid personality, you have a lot of anxiety socially. Like if you have to go somewhere, go to work or whatever, in any kind of group, you start having a lot of physical symptoms, sweating, which is embarrassing for you, which then makes things even worse, pounding in your chest, and you just can't even deal with it. But you have to work. Let's say this is a job related kind of thing. You have to work, you got to go in. Now it's hybrid. You got to go into your office and, you just want to go in and close your door and be left alone to work. But you got these meetings and, so the medication, your doctor could prescribe a beta blocker to address the physical symptoms of the anxiety that really is derived from your personality and your like inability or difficulty dealing with interacting with people. But the beta blocker is not going to make you interact with people better. Like it's not going to improve that problem, but it will help how you're coping with it, or the physical or the anxiety that erupts or comes from it. So that's an example of using a medication to help an issue that comes from your personality, but you're not treating the personality. So using the beta blocker, it could help you not have the pounding heart. It could make you, excuse me, not sweat and all of that stuff that's evidence that you're anxious. But you still just have a disdain for not wanting to be around people or have difficulty knowing appropriate things to talk about, appropriate as judged by the other people. So, it's fine to you, but they don't want to hear about that, or have difficulty understanding or getting what people are talking about, inside jokes and stuff like that. And all that stuff makes you uncomfortable. All the more reason you just want to go to your office and shut the door. So that stuff, again, a medication isn't going to make you be better, make your social skills any better. But if those difficulties you have with the interactions end up making you depressed, then yes, something like Wellbutrin can help your depression, but then you still got to work through the interaction issues that you have that are derived from your personality. So that's an indirect way that I see medication helping a personality. You're not changing the personality, you're helping the negative effects of your personality. Okay. What else we got here? Ahmed, greetings from Egypt. Wonderful. Thank you from Egypt. BC says, just want to say thank you. Wonderful. You're welcome. Santanen, what's the difference between a sleep psychiatrist and a sleep neurologist? Okay, so thanks for this question. A psychiatrist, so psychiatrists and neurologists are both physicians. And actually, our boards are governed by the same entity. It's the American Board of Psychiatry and Neurology. So neurologists, though, we take divergent paths after internship, and neurologists focus more on the nervous system and abnormalities and conditions involving the nervous system, more of a physical manifestation. So, I mean, in theory, I guess, we psychiatrists deal with nervous system as well. If you're anxious and you're, in your brain, but brain derived things like depression and all that are still your brain. That's part of your nervous system. But a neurologist would deal with, I'm probably not saying this right, very well or succinctly, but, things like seizure disorders or any kind of malfunctions of the nervous system of your nerves or parts of your brain that have physical manifestations like, certain neuropathies, or if someone had a stroke and, which would be damaging part of the brain and then affect part of the body. Okay. Long story short with all of that. Some psychiatrists choose to focus on treating sleep disorders, and they could do that either by, and neurologists as well, could focus on treating sleep disorders. They could do that either by addressing, the psychiatrist could address more of the like cognitive behavior therapy for sleep management. It's called CBT for insomnia. So be focusing on therapies and medications. The psychiatrist could also get additional training on sleep breathing problems. So things like obstructive sleep apnea or narcolepsy. But in general, something like narcolepsy would be more in the wheelhouse of the neurologist. So a sleep neurologist, their focus of treatment may be more on if you have a sleep problem that is because of something like narcolepsy, restless legs, or a byproduct, a negative byproduct of some other neurological problem that you have. Multiple sclerosis is really a neurological issue. So, or that person would see a neurologist, I guess I should say. So, so really the difference between the sleep psychiatrist and sleep neurologist would be their focus of treatment, really, with the psychiatrist maybe focusing more on therapies and medication, the neurologist focusing on treatments related to whatever physical cause of the sleep problem was. They may even get special training in some of the sleep breathing things like sleep apnea and prescribing CPAP and all of that. It just kind of depends. The whole sleep medicine thing, there are different specialties that if you got additional training in it, you could still be doing those things, even though that wasn't your primary focus before you went down that road. All right. Thanks for that question. Dulce, Vita Slots. Thank you for the super chat. My depression is getting better after 2 months after panic attack, but still waking up with anxiety stomach every morning. Will it go away? Not on meds. You're not on meds. Thanks for adding that in. So let me see this again. Depression is getting better after 2 months after panic attacks, but waking up. So I wanted to read your question again because this is a touch unrelated, but I still just kind of wanted to, this came to my mind. I've had some people who had some kind of panic attack, like had the experience of a panic attack, and then like had all this fallout afterwards. And sometimes it was because of like they smoked something or took something and then had this panic reaction. And then later on, like months later, they're just like, I'm still not right. Like that thing I did caused this permanent damage in me. And the answer for these people that I interacted with was no. Probably what happened is whatever you smoked or took tripped off, this vulnerability that you have to anxiety, or even depression in one person's case. And so it's just either coincidence or just a trigger that then kind of led to this longer term issue that followed. But so it's not like, I had a panic attack and now I'm depressed, and the panic caused me to be depressed. Now I know you didn't necessarily ask that, but I wanted to bring that up because I've kind of heard questions about that kind of before. All right. So you're not on medication and you're still waking up with a nauseous stomach, which is very unfortunate but very common too with anxiety. Kind of wake up anxious. It's like, what have I got to be anxious about? I just woke up. I wasn't thinking about anything. So without medication, you could, it's okay. There's not a quick, simple answer to this. My thoughts kind of off the top of my head would be to start, practicing things like, morning. So put in more like relaxation activities and meditation and mindfulness into your routine, both at night and in the morning. And then I have one more suggestion too. So things like morning yoga, like if you wake up nauseous, you might not feel like, well, I don't feel like downward dog, I'm going to throw up. Okay. Well, how about doing some kind of like progressive muscle relaxation or something to help kind of calm your nervous system? It could be breathing activities. It could be a rapid change in temperature, like splashing cold water on your face. Like these are vagal maneuvers or things that activate your vagus nerve to help calm you physically. Sometimes though, that's not enough because the experience of waking up feeling anxious can then get your mind running and like, what's wrong with me? I got to stop this. I got stuff to do. I don't have time for this, da, 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 da. So the vagal maneuvers will address from here down, like relaxing your body, but you still got to do something with your mind and what's going on running in your mind if that's happening to you. And that would be where things like mindfulness, practicing some mindfulness activities or grounding exercises could help. I have a bunch listed in my book, Why Am I So Anxious? I got in a plug. And I have a bunch of grounding exercises in that book. You can find it on Amazon. How long, though, it should last, that's hard to say. So this could be something that if you've got something going on in your life that is just stressful for you. So, I'm thinking of someone who has a job that's a little bit out of their comfort zone, but they still make it work. And this person is prone to anxiety, in that prone to worrying about things, self-doubt, and perfectionism and that sort of thing. And so this job that is just still that this person is not quite comfortable with generates anxiety for them. And they know this. They know that every morning when they wake up, they're anxious about work and whatnot. So in that person's case, just simply, thinking of 5 things or looking at the colors in the room. This is like a grounding exercising, picking everything in the room that's brown and focusing on it and naming it. Like that still might not take that away because some of that still is work. generated in the anticipation of showing up and having to do this stuff. So in that case, it takes a little bit more than just trying to settle your mind when you wake up. If you don't have that, then it's about trying to settle your mind and your body when you wake up. Another thing I do want to throw in here, it does involve putting something in your mouth, is ashwagandha. Ashwagandha is a natural supplement that has been shown to reduce cortisol levels. And high morning cortisol levels, very high morning cortisol levels, are associated with this waking up anxious thing. Now, we all have an increase in cortisol in the mornings as part of just our body clock and the way our body works. But with the idea with the morning anxiety is that it spikes high. So I've had some patients where I recommended ashwagandha and they've taken it and did notice an improvement, particularly in the morning nausea stuff. It was still in these people, and it's not a bunch, it was still, it was more like a ratcheting things a notch down. It wasn't like, oh, I'm not anxious or nauseous at all. I'm ready to go. I mean, it wasn't that dramatic, but it was enough for them to feel encouraged and be like, okay, this is better and I can do this. So if you are into taking supplements and you don't have any medical issues that would interfere with that and all that, that may be one thing to look into. It could be enough of an improvement to give you the ability to then do other stuff like some yoga in the morning or some deep breathing in the morning, or to do these things that are harder to do if you're just like in a state. It could like kind of ratchet down a little bit, enough for you to do more to then help overcome that morning anxiety. Thanks for that question. All right, Leon. Hi, Dr. Marks. Thank you for all your help through the years. You are welcome, Leon. And I just want to say, we have been going almost 2 hours. I am going to go about another 10 minutes until noon, and then we will call it a wrap. Time flies when you're having fun. Snooze addict. I love that. Thanks for your content. It's very helpful. I appreciate you. Thank you, snooze addict. I'd love to know how many times you press snooze. Hello from South Africa. Thank you, Jean-Marie Meyer. My son we have a process of 3 alarms, each 15 minutes apart. We have these Sonos speakers. I don't know if you're familiar with those. They're like connected by Wi-Fi. And so the first alarm goes off and it blasts music in his room, wakes me up. And then we listen to that for a couple of minutes. That goes off, and then he gets to go back to sleep. And then 15 minutes later, the next one goes off. And then I do this thing. My husband says it's overkill, but I then go in at that second alarm and turn on the space heater so it's easier for him to get up. I know I'm probably babying him, but I can't help it. And then I remind him, okay, at that next alarm, that's when you need to actually get up. And he goes, okay. And then the third alarm goes off. I take in a cup of Monster drink for him to help him get up. And he finally gets up. So that's his snooze process. Just thought I'd throw that in for good measure. He said, snooze says, I snooze at least 3 times. I'm working on it. Yeah. Sometimes though, there's just some like satisfaction in knowing that you don't have to get up that first time. I kind of like it sometimes when I wake up accidentally and I look at my clock and I'm like, oh, good, I have another 30 minutes. It's not time for me to get up yet. It's like, I can't. Now, 10 years ago, I could just pop up. Okay, ready to go. But now it's kind of like, okay, I need to just like process before I get up. So that's for me, that's where snoozing can work well. It's processing time. All right, Foxy Brown. Love it. Hi, Dr. Marks. Ashley from San Diego, California. I'm pregnant and have PTSD, ADHD, and severe anxiety. Boy, do you have any home remedies for severe panic attacks outside of meditation and affirmations? Home remedies. Well, first of all, congratulations on expecting a baby. Um, and I'm sure that's very tough dealing with anxiety, taking nothing, and your ADHD too. Although I shouldn't make assumptions. Some people do continue their medications during pregnancy. Um, Home remedies for panic attacks. So the main thing that comes to my mind is, excuse me, the vagal things, the vagal maneuvers that I was talking about. I have a video on it as well, because that's the closest to like a physical manipulation of your body versus like with meditation, it's you're thinking like that's brain work. And if your heart is racing or beating and pounding, you probably can't even focus enough to be thinking about something in your head. You're just like, so the vagal maneuvers would be things that don't require you to have to think a lot. And again, those would be things like splashing cold water on your face. Or you could do it as putting cold water on a washcloth and then putting it on your face or even on your chest. So it's kind of like head and neck and chest. Vagal, I know I called it vagal maneuvers, but because the vagus nerve, but there's also the, Valsalva, that was the word I was thinking of holding your breath and holding your nose and then blowing out like you were trying to pop your ears, like if you were under pressure or in an airplane or something. That's another one. Or even if you don't want to go that far because it's uncomfortable, holding your breath is another vagal thing that can trigger your vagus nerve. Humming is another, because the vibration of your vocal cords are located kind of close to your vagus nerve, which comes out of your head and down into your body. So that's kind of the basis of the when people are chanting and things and humming. So that's another thing. Those are the kind of the main ones. And that's really the only thing I can think of those kind of things doing. And I will say, you probably have to do them more than once because, and I've heard people say this, is like, well, it works, but it just doesn't work for very long. So maybe if you're already doing meditations and affirmations, what you could do is pair the two. So you can maybe extend the time of how long you feel improved. So you do some breathing exercises or hum or the water. And if like for a couple minutes or a couple seconds, you feel a little bit better, then launch into something like a meditation. It could be guided too, like guided meditations that you would listen to on like Headspace or the Calm app. That can help you not have to do the work yourself of trying to think. You just follow someone's directions. Oh, you know what? I just thought about something else that's physically based, tapping. So the actual term for it is emotion freedom technique, EFT, but tapping. There's an app, this is not sponsored, called the Tapping Solution. That's one that I'm familiar with, where you do these tapping exercises where you tap at certain kind of like meridian points on your body as you talk through some issue. And for some people, it's very effective and very helpful. With something like this app, you can again be guided, and you're not coming up with the script yourself of talking out what you can think about. Excuse me, sorry, that's making you anxious, and then tapping in these spots. You don't have to come up with that yourself. You can listen to someone talk you through it. So I'm glad I thought about that last minute. That's another solution or home remedy, if you will, for panic attacks and anxiety. All right, I hear the music. Thank you guys for showing up and having such great questions. And we'll have to do this again. Let me know in the comments if this was helpful enough to want to do again. All righty. Have a great week, and I will see you next time. Bye-bye.